To the VetWell podcast.
Thank you for having me. It's an absolute pleasure.
Thrilled to chat to you. It sounds like from our off-air conversations that we're going to have to talk about telehealth and all of the other stuff that you do with vet triage. But today we are talking about thoracotomies, big surgery.
Yes, very excited to talk about this.
So, and we were just talking off air about people referring stuff away that they could or should try before they just handball it to the specialists. This is a procedure that I have always handballed, thoracotomies, if at all possible, just because it scares the shit out of me. It just feels really scary to cut into a thorax. I'm happy to cut anything else, but there's so many things in there that are pretty important. But I think probably the most scary part to me is the anesthetic, maintaining, once you lose that pressure, ventilating it. But can I start with that? Is it worth being that scared of? Is it a big, scary, difficult surgery, or is it achievable for a confident GP surgeon?
It does depend. The most common question that I do receive from the audience when I give talks on any procedure, whether it's a splenectomy or a hemilaminectomy, whatever it may be, is, do you think we can perform it as a GP? And the answer is maybe. It depends. A lot of it comes down to equipment availability. Is it worth having the equipment that you need for this procedure? Do you have the diagnostics required for this procedure? And then, of course, the skill set and experience to perform the procedure. Does the client understand what it is that you're offering to them versus referral? And then the post-operative care. Are you equipped to deal with the patient afterwards in a hospitalized setting? Can you deal with the complications? Can you troubleshoot things that come up? And so you have to answer all those questions before you decide whether or not you can do something. It's easy to make the argument that something like a splenectomy or really any intra-abdominal surgery, most folks have the basic diagnostic tools for these things and the equipment already there. If you perform a SPAY, you can pretty much perform any intra-abdominal procedure, give or take. But the thoracic surgeries are going to be a bit different. They require a higher level of diagnostic equipment, and they also require a higher level of, like you mentioned, anesthetic control, as well as surgical tools that are going to be pretty unique to a thoracotomy. So the answer is maybe it's scary, maybe it isn't. It all depends. But I think what trumps all of this stuff really is client communication and your own experience with performing the procedure. You want to be upfront with the client and let them know that there are board certified specialists that perform this fairly routinely. If you don't have access to them or you can't afford that level of care and you want me to take a shot at this, understanding the pros and cons of that, I would be happy or not happy to in my facility. And then from there, you have to make kind of an ethical judgment. Well, should you be offering that to a GP or not? Or rather, should you be offering that to a client as a GP or not? It's up to you to decide. But that's a complex, great answer to what seems to be a very simple question.
Yeah, I want to go through those list of things, the equipment and the diagnostic tools and stuff, step by step. I'll make this personal. So I'm 20 years qualified. I've done a ton of surgery, most scary abdominal things. My hands are capable. I work in a hospital now where we have very skilled nurses who can do thoracic anesthesia. We have a ventilator. We have all the tools. The limitation is my confidence levels, really. It's a big, scary surgery. Again, technically, is it much harder than a enterectomy or a big abdominal surgery? Like, should I stop being a wuss and take it on?
If you've got the right client, the right case, and it's set up appropriately, then yes, you can certainly take this on. Again, you're going to want to perform, what I recommend doing is perform the procedure on cadavers beforehand. This is, of course, assuming you've got a case that's not an emergency. It's not a life-threatening emergency like a lung lobe torsion or something like that. If you have time to prepare yourself, cadavers are a great way of practicing the surgical part of it. Obviously, cadaver won't help you with the anesthetic portion of this, but you already are almost there. You've got the experienced staff. You've got the ventilator, that's huge on its own. You don't necessarily want to be stuck manually ventilating a patient. You need mechanical ventilation for this, ideally. And then, of course, do you have advanced imaging or not? Most of us aren't going to cut, or at least as a surgeon, I'm not going to cut just based on radiographs. I'm going to cut based on a CT scan, maybe an MRI, but usually CT. And so if all that stuff's lined up, practice on a cadaver, get your skills honed as possible, as perfected as you can, and then tackle that first case with the clients, understanding that this is what you're doing to help them out and help their pet out. So yes, sure, why not? As long as everything's prepped ahead of time, sure. You don't necessarily want to see yourself doing this for the first time on an emergency thoracotomy or something. I mean, I know doctors who had to, sure, by all means, if you have to, you have to, but you want to kind of prep ahead of time.
Yeah, we'll get into the indications of when are we going to do this, including those emergency ones, because to me, that is the reality. I might suddenly be stuck in a situation where I need to cut now. Can I quickly ask you about the imaging, the advanced imaging? Why, or maybe that ties into the indications of when we're going to do thoracotomies, but why do you prefer CT or MRI? Are you talking specifically about lung masses or foreign bodies or things like that, where you want to be specific anatomically of where exactly you're going? So I'm thinking for stuff that I might need to cut urgently, exactly as you said, lung lobe torsion, massive dog bite wounds with a penetrating chest wound, we've got to go and flush or maybe cut a damaged, things like that. Why specifically advanced imaging?
The imaging is used for two reasons. One is for staging purposes. Let's say you are dealing with potentially a primary pulmonary mass. You want to stage the patient. And so advanced imaging helps with staging, not just full body scanning to look for metastatic disease anywhere else in the body, but also within the actual lung parenchyma too. So that's one reason. And the second reason that you already alluded to is surgical planning. You want to be able to plan these things out. You want to know the exact lung lobe, let's say, that you're chasing after. Or if it's a chylothorax case, you want to know that, is this a case where it's worth performing multiple procedures on one patient or not? And can I figure out a cause for this chylothorax case as opposed to just labeling it idiopathic, because that's what most of them are, and moving on. So you use it for staging, you use it for surgical planning. You could also consider, you can say, well, what's a poor man's way of staging these pets? In most cases, what I've done is 3-view thoracic radiographs, abdominal sonogram, and there you go. But that takes care of the staging part for the most part. It won't necessarily help you with the surgical planning. And now, you could argue, well, if I see a glaring large pulmonary mass on radiographs, I know what side it is. I know approximately how to gauge which lung lobe might be affected by it. And most of the time, you're performing a thoracotomy, an intercostal thoracotomy for a lung lobe mass. Between intercostal spaces 4 to 6 is roughly where you're going to be anyway, left or right, depending on the lung affected. But regardless, can you cut based on an abdominal sonogram that doesn't show any metastatic disease, radiographs that show clearly a large pulmonary mass? Can you cut that way? Sure. Just communicate with the client that's key here. That's what we're doing. It's not necessarily subpar medicine, but you don't want to dive into something like that without having the client's consent that, hey, you could get fancier with this. I could send you to a specialist. They could do CAT scans and all the other fancy stuff. But this is an emergency case, and you've got 3 hours to drive to the specialty center. Your dog may not even make it till there. We can offer this option, have them sign off on it, and move on, save a life.
Okay. Can we quickly cover common indications for when we want to do these? So urgent ones, but can frame what are we actually talking about. So I mentioned probably the most common one that I would and have been faced with is the penetrating chest wound dog attack, where you need to go and explore. And that includes going into the thorax. As you said, lung lobe torsion, I've not actually seen it, luckily. I've not had to make that decision yet. And we'll talk about what that involves. Hernia, diaphragmatic hernia, does that count as a thoracotomy? Or I suppose you're going through the abdomen, but does that count as a thoracotomy?
I can't remember what we used to categorize it under for my surgery residency. It's been a while now. I can't remember if they considered that a chest surgery or abdominal. I think they considered it abdominal surgery, but the surgical approach is abdominal, even though you're clearly entering the chest inadvertently because of the hernia. You're not necessarily entering it for the treatment purposes. However, you're going to place a thoracostomy tube in those dogs anyway, and although you could do it transdiaphragmatically, I'm a fan of performing the chest tube placement intercostally instead. But again, that's not really, your question pertains to the procedure itself. It's really an intra-abdominal surgery, even though it's, yeah.
I'm trying to think what else. Esophageal access, so foreign bodies would be something that's relatively urgent, yeah?
Yeah, absolutely. Esophageal access, you already had mentioned trauma for sure, penetrating foreign bodies, lung lobe torsions, we've already mentioned. Don't forget congenital vascular disorders, PDAs, things like that. Pericardial effusion or tamponade cases also, you could make the argument for that as well. Bulla surgery as well, pulmonary bulla. So those are all different indications for it. Primary pulmonary lung masses, portoazygous shunts that you have to access via thoracotomy. It's another indication for it. cranial-mediastinal masses.
Yeah, I feel like for the purpose of this conversation, when we're talking to non-specialist surgeons, I think most of us, if possible at all, the cancers, the shunts, that's not urgent, we're definitely going to try and refer. I don't know. Personally, I just go, look, there's somebody better. It's the stuff that's quite urgent. We go, crap, something needs to happen. You know, dog's got a bone stuck in his esophagus and it's penetrated through the esophagus. Too expensive or too far away or whatever, and either it's going to die or I'm going to try. These are probably the sort of things that we want to see if we can help people with those ones. And again, I think the purpose of this podcast, it's not going to be you're going to listen to this podcast and then be able to do it, but hopefully get some advice on what mistakes to avoid and things to think about before we jump into this. Yeah?
Absolutely. And I think it's a massive point to make, because I tend to also be much more clinical than academic, to go through even the details of what muscles you're going to go through and what you're trying, the nuances of this stuff really does require not just a clear look at the academic information, but also, again, trying it yourself with cadavers. So I'm glad that you said that.
Okay, great. Can we talk about the equipment? So we've mentioned imaging equipment. We won't talk about the anesthesia. We did actually do an episode a while ago. For anybody listening, scroll back. There is a specific episode on an anesthetic for thoracic surgery. So, I mean, ventilator, all those things. I won't make you do all of that today. That's ideal. Beyond that, what would you say would be the ideal things to have in a hospital before you attempt thoracotomy?
Yeah, so the biggest instruments, or category of instruments rather, any kind of self-retaining retractors are going to be great for the, like Finocchietto rib spreaders, for example. You're going to need some sort of self-retracting instruments there, because you can't have an assistant hold open the rib spaces the way you can have an assistant hold open the abdominal cavity for you, right? It's bony boundaries. So you need a self-retaining retractor of some kind that's really made for the chest. Could you finagle a Balfour retractor in there? Maybe, probably, but they're not that strong compared to the rib spreaders or chest retractors that you're going to want to use. On top of that, you're going to want surgical instruments, your typical surgical pack, that have longer handles, because you're going to be working deeper in a cavity. So you want to have needle holders and forceps that have a bit longer reach, because you're going to be working in a cavity. You're going to be limited by how much rib spreading you can perform in this surgery. So if you're having difficulty, you're at your maximum with spreading the ribs apart, you need longer instruments. Or now you're looking at, do you do multiple intercostal thoracotomies, or are you now resecting a rib to increase your access, which, if you can avoid being more invasive, you'd like to, but you also don't want to struggle the whole time either, because you might have a patient who's compromised. And so time is of the essence too. So those are two key categories of instruments that you're going to need. And then if you're looking at the actual procedures themselves, for example, it might be easier to go surgery by surgery. But let's say, for example, you're going to perform a subtotal pericardectomy. A ligature advice or some sort of large bipolar cautery device is invaluable for that type of procedure. And so then anatomy, of course, it could be expensive. So you want some sort of really fancy, high-end bipolar cautery device if you're trying to remove the pericardium, for example. Or if you're going to remove a lung lobe, are you going to go with hand sutures, or can you find a stapling device made for the pulmonary tissue? And of course, those come in all different shapes and sizes, and then you have to learn how to use that, because obviously pulmonary leakage post-op is going to be a problem. So those are other things you need to consider as well if you're looking at surgical equipment. You could make the argument, like, for example, you're going to need a chest tube for these patients, so probably a red rubber would be sufficient. You might need a feeding tube if you're talking about bypassing the esophagus for esophageal surgery. So again, red rubber probably is sufficient. I haven't done it myself, but I've seen surgeons use different kinds of mesh for esophageal resection, anastomosis, or even an esophagotomy where the incision is still kind of questionable viability. They'll place a mesh over it to help augment healing. Again, just depends on how fancy you want to get with it. I haven't even done that. I've seen it before, but it doesn't seem to be that common, at least from my experiences.
So with the spreaders and the retractors, let's say somebody's listening to this and they go, oh, I'm going to buy some. Do you have favorite types? You mentioned some Italian name that I've never heard of before. Like, do you have stuff that you like personally that you go, these are my favorites?
Not really. And that's why I would suggest probably, because you're going to dive into the world of thoracotomies and for them, not just for emergencies, but also for like planned procedures, then you're going to do your homework, and you can start off by buying one retractor that are made to spread the ribs, and then use that on a cadaver and see what you think, and then go from there. It's whatever's going to end up working for you is fine. But there are retractors that I can't recall the name. I can envision the shapes, but the names are always these human names that, who cares? But Finocchietto is just one of the common ones that I'll use, and that just sticks in my head, that name. But they all have a similar look to like a Balfour retractor, except that they usually have some sort of a crank on them where you can gauge how much tension you're putting on the rib spaces, as opposed to a Balfour, which is just spread them until you just don't want to anymore, or until you can't anymore. Much more crude. The rib spreaders usually are a bit more calculated in how you spread them. And also, the retractors can't be in your way, right? So they have to be able to retract and also get out of your way. They can't be in your cervical field. So the handles need to be out of your cervical view and out of the way. And so that's how they're going to be made.
And with the Balfours, is that a problem? Are they a little bit in your way?
Yeah, typically it's not an issue unless you're working really deep into the cranial aspect of the abdominal cavity. If you're trying to really get into liver or even towards diaphragm, it can be a bit annoying. But usually the solution to that is easier. You just make a longer incision, and then you move the Balfours cranially. With the chest, you don't have the luxury of that, right? There's only so much room that you can move. The more dorsal or ventral you move in the thorax, the more limited rib space you have, and so it doesn't really help much. Again, unless you're going to resect the rib or perform multiple intercostals, but otherwise you're limited by what the retractor can do for you.
Okay. Is this a good point to start about where we can cut? So you said before, obviously, if you have a clearly defined problem that is there, then that's where you cut. That's where the tooth's gone in, so that's where you're going to cut. But what are the limits of accessing the thorax? Like how far north and south and east and west can you travel on the thorax?
The good thing about the intercostals is that, well, it is with any surgery, you can always make your incision bigger, right, if you need to, but you're going to start off small, as you typically would. And the good thing about the intercostal thoracotomies is that it's hard to go too dorsal, too ventral and get in trouble, because you don't really gain much improvement when you do that anyway, when you extend your incision that much longer. So ventrally, what you're trying to avoid is the interthoracic vessels that sit right on the floor of the sternum. Again, it's hard to imagine you going that ventral, but who knows? If you're trying for the first time, then sure, I suppose it's a possible error, but you don't want to go. And then, of course, the more dorsal you go, the more heading towards aorta and the sympathetic trunk, you're going to start heading towards them. And again, it's hard to imagine you going even that dorsal by accident, because it doesn't really benefit you much to go that high up. So, yeah, so you're pretty much going to be naturally bounded anyway by what the thoracotomy benefits you for when it comes to surgical approach. But regardless, I would say probably if you imagine separating the rib into 3 sections, you're going to stay in that central third of the intercostal, and then the proximal distal thirds you're pretty much going to stay away from, but you have room to encroach if you need to. Obviously, you're going to be looking at drawings of this too to see, but it's really hard to get too dorsal or too ventral on these anyway, and it won't benefit you much.
And then in terms of cranial coidal, which sort of rib spaces are the ideal window? You mentioned it earlier, I think. What's your ideal approach if it's not a bite wound or something that you're limited by that?
Because after the bite wounds, like penetrating foreign bodies, if you're trying to chase something in the chest, in terms of most common diseases, you're stuck with either lung lobe torsion or pulmonary masses. And as long as you can pinpoint on a radiograph or a CT exactly which lung lobe you're going to pursue, then most of the time, the 4th to 6th intercostal space, left side for left side of disease, right side for right side of disease, that 4th to 6th intercostal space is pretty much going to get you access to the lung lobes. Again, there's some finesse with that, right? You want to be a little bit more precise if you can, but in general, if you're trying to do this without high-end imaging like CAT scan, 4th to 6th intercostal space will get you access to the lung lobes, generally speaking. Also, don't forget too that the intercostal vessels and nerves do run together, and they run along the caudal aspect of the rib itself. That may come into play more so with closure than it will with approaching it. But again, you want to keep that in mind, that the nerves and vessels are pretty glued to the caudal aspect of the ribs as well. So when you make your intercostal incision, just be conscientious of that.
Okay. What about esophagus? Let's say your standard esophageal foreign body that's stuck over the heart and that sort of area. Same thing, 4 to 6. Will that give you access?
That's a bit trickier. So even if you look at the charts that we all use as surgeons, and these charts I reference all the time because I keep forgetting, for the esophagus, at this level, do I approach left or right side? That can be a bit tricky. So even those charts, you'll see like esophagus and it'll be blank. There's nothing there. Because it'll depend. So sometimes in that case, it doesn't really matter where you go. And so most time, and again, and also I will say too, in terms of the incidence of esophageal foreign bodies, I get kind of spoiled because I typically have like an internist there. And so if they can scope the thing out or push into the stomach and then I'll perform a gastrotomy, great. We all love to avoid esophageal surgery if we can. So it may not matter left versus right side, or it just depends on what the imaging is going to show. And then you just use common sense from there as far as which left or right side and which intercostal space. You're going to be targeting right over the foreign body anyway. So the space may not matter too much. You can base it on radiographs, but left versus right is going to depend on where the foreign body is, and it may not even matter. You can, if you want to get fancier and you have scoping available, you can also place a esophageal scope, GI scope in the patient during the procedure. And before you enter the esophagus, you can poke around and hopefully look at your movements via scope. You perform your thoracotomy. You want to make sure you're over the right area of the esophagus, or make sure that it is esophagus and not some large vessel or something that can be hard to decipher. And you kind of push and look at the scope and make sure that you can see yourself on the scope before you cut into that. So you try to minimize these errors by using all these tools to your advantage.
I didn't even think about that. That you just assume that when I'm going in looking for an esophagus, it'll be, there it is. But what you just said there, you don't want to mistake the aorta for the esophagus and go, let me cut that.
Man, I'll tell you because here's the thing with esophageal foreign bodies again, and I'd love to hear your experience with them too. I usually don't get them referred to me till at least days, if not weeks, after the problem occurred, because these pets they just look miserable and they get more miserable over time, but they may not have a complete obstruction, so they can still, some food and water will still bypass the foreign body, but they're struggling. And so I see them. By the time I see them, it's already, do they have an esophageal perforation? Do they already have a pyothorax? And now they're fairly destabilized. It's a crappy case all the way around because I didn't get it on day one. I got it like by week 3. And sometimes the radiographs are not that clear, because you can look at the esophageal foreign body and convince yourself that's localized bronchopneumonia. I mean, it doesn't always look that crisp on a radiograph, especially if it's a chronic obstruction. I wanted to circle back, by the way, to the using the scope intra-op. If you don't have a scope to use intra-op, you can pass like an orogastric tube. As long as there's something large bore that you can pass in the esophagus, so you're cutting into the esophagus before you cut. The scoping is great because you also look at perforations intra-op. Not every perforation is going to be very grossly visible to you, but a scope might help magnify it. But if you don't have a scope, you can try and pass a large bore orogastric tube too, just so you know, and then you can delineate the esophagus more clearly intra-op.
Those are the kind of tips I like for these podcasts. That could be the difference between accidentally cutting the aorta or the vena cava or not.
Also, not that you want to get too aggressive with the esophagus, but it is ideal if you can either retrieve the foreign body in the esophagus using a scope, or if you can push the foreign body into the stomach. It's a much easier problem to deal with a gastrotomy. Now, again, you may not necessarily know there's esophageal perforation, especially if you don't have a scoping available to you until maybe days later or something. But if you're able to somewhat easily pass a foreign body into the stomach, it is preferred.